Dr. Dearborn is the Mary Ann Swetland Professor and Chairman of the Department of Environmental Health Sciences and Director of the Swetland Center for Environmental Health at Case Western Reserve University School of Medicine. In addition, he's a Professor of Pediatrics in the Pediatric Pulmonary Division, Department of Pediatrics, Rainbow Babies and Children's Hospital in Cleveland, Ohio. His training, clinical practice, and research interests combine biochemistry with pediatric pulmonary medicine, especially as impacted by environmental fungal exposure. He is co-chair of the Greater Cleveland Asthma Coalition, a member of the Healthy Homes Advisory Council of Greater Cleveland, and served nationally on the American Thoracic Society's Environmental Health Policy Committee, and is on the Scientific Advisory Committee for the National Center for Healthy Housing. So please welcome Dr. Dearborn.
Thank you, Kevin, and thank you for the invitation to this summit. And thank you to HUD for sponsoring the summit. So, this statement holds true for almost all asthma patients. And I think that we can begin to understand why it is true when we look at the major difficulties. Not moving forward. Yeah.
And the arrow's not working either?
Right, the arrows are not working. So there are two major difficulties that take through, and that is compliance. That is adequate education and what the medication and the medical care plan is, and maintaining that in the patient's home and family. The second one is environmental triggers. And what we'll hear about today is how best to combine both of those. There we have compliance and environmental triggers. Okay, so we've been hearing about how large the problem is nationally. We heard from Jose this morning that we're dealing with about 9% of children across the United States currently have asthma, and that this is costing our society $50 billion a year, mostly in the form of 500,000 hospitalizations a year. And so taking it home to my home county, Cuyahoga County in northern Cleveland, northern Ohio, you see in terms of current asthma that there is county-wide a differential across racial distribution, but within the inner city that is removed. So that we're dealing with almost twice as much incidence of asthma in the city of Cleveland than what is the process nationally. So how does this translate into our children's hospital? Is in 2001, we had over 500 admissions where the primary diagnosis was asthma. 3 times that when asthma was included among the list of diagnostic reasons for admission. And that this has been holding fairly stable, as you see, over the past 3 years. A third of these patients have required intensive care unit time. Fortunately, not very many have required readmission within 30 days. And the length of stay with a standard care path that we've had existing for the last 20 years, we've been able to decrease it to less than three days. Our county hospital has about a third the hospitalization rate for children for asthma. And who are the payers? Well, you can readily see that Medicaid is the vast majority. That's where we need to sit our attention for our thinking today. So in terms of keeping patients out of the hospital, there is a medication approach, and in the past 10, 15 years at least, we've moved very, very well in this area with controller medications and rescue medications, keeping the vast majority of asthma patients in good control. And with adequate compliance, this usually works. There is a newer medication that is used in the very severe patients called Xolair. This is a humanized mouse monoclonal antibody against IgE, the antigen antibody. It's a protein, so it requires repeated subcutaneous injections every 2 to 4 weeks. And it's very expensive, as you see. Not only transportation and parking for the family, the center has to have a nurse dedicated to it, or at least quarter percent of the time dedicated to it. But look at the Medicaid allowable charges. If the patient is at the low end of every 4 weeks, and at the lower dose, it's $19,000 a year. But in our center, 72% of the patients are at the higher every 2 weeks, $2,200, for over $57,000 a year per patient. So this gets to be very expensive very quickly. And this, of course, gets the attention of the Medicaid payers very quickly. So, as we've been hearing from Peter Ashley, he set the scene for this in 2007, and NIH had their expert panel. And they underlined the value of including in the medical asthma management plan addressing the inhaled allergens and irritants in the home, that this would decrease the medication use, and that they needed to be multifaceted. And as you also heard from Peter, you see that following NIH's guidelines, the EPA guidelines for the next year, CDC's task force the next year, and even an international group. So with all these expert panels saying that the home environment has got to be addressed in part of the medical care plan, why isn't it standard of care? We are 6 years out from that initial recommendation. This has got to be brought to the standard of care across the country. And we're about that. We're addressing that issue here today. That is, how do we move this from recommendations to practice across the whole asthma population in our country, and it's obviously who pays for it. So a panel that CDC and the National Center for Health and Wellness put together several years ago identified the evidence-based approaches for the home environment approach to keep the patients out of the hospital. Smoke-free being the first one, the multifaceted interventions. Of course, key integrated pest management. This is a key component that we're going to have difficult getting the Medicaid people to pay for, because this is strictly environment. But that we need to keep part of it. And then also getting rid of moisture and mold. So these are the ones that were raised to the level by this panel of the sufficient evidence for incorporation into the home program. Well, let me talk briefly about the program that we've learned now in our 8th year in Cleveland, called the Case Healthy Homes Patients Program. So the asthma portion of that starts with the pediatric pulmonary physician at our children's hospital referring their patient to the program, and then a home health inspector from our community nonprofit organization, usually taking one of the pulmonary fellows out on the visit. That is, inherent in this is an education of the physician in terms of hands-on experience out to that home. And the action plan is devised then with the physician in charge of behavioral education, and the inspector then providing the home health and safety items and doing the interventions, and the physician then following up. So that's the basic program. So what have we seen with this program? Well, we stopped and looked at our experience a year or so ago, and if we take the 27 asthma patients where we had done the home visits on, and looked at their hospitalizations the year prior to the home visit program, you see that 27 patients were hospitalized 50 times. Almost 40% of them spent time in the intensive care unit, and 6 of them had to be readmitted. So what happens after the home visit? You see a dramatic decrease in the hospitalization rate, PICU rate, and keeping them out of the hospital. it was this figure that got Matt Adams' attention, and so and asked us to have the first of these summits in Cleveland last fall. So what does an optimal home visit look like? We've stepped back and looked at what we've been doing, what other people have been doing, and discussed it at the summit, and this is where we have come up with what the optimal program should include. We would see targeting the asthma population to the most severe. Now, when I say optimal home visit program, this is the ones that we would need to convince the Medicaid folks, whether it's the Medicaid state agency directly or the managed care organizations, as to what is the best way to run it. And so we would see that the most cost-effective would be to take the more severe patients and tie it very closely to the medical care system. That is, it would require a physician prescription, if you will, and as was asked for in the 2007 NIH guidelines, along with that referral would come the written medical care plan from the physician. And optimally, if there is the allergen prick testing already done, then that's helpful in directing interventions. So the home visit then is structured in at least 3 ways. Of course, addressing the environmental triggers, but inherent in the inspection and review of the home is taking the mother, head of household, along with that walkthrough and giving them immediate hands-on education as to what those triggers are and what can be done about them. And then inherent in this visit, we feel it's important to have case management continue addressing the compliance issues. And then to finish the loop, the report, there would be a formal report going back to the referring physician for the medical chart. Again, to tie this into the medical system, and that the service providers should be certified. Not necessarily a nurse, not necessarily a physical therapist, but a certified housing inspector and a certified asthma educator. And those could be community health workers. And that this should be then supported by a fee system. So this is an estimate of what this sort of program would cost from, as put together by Environmental Health Watch, our longstanding nonprofit partner in the Cleveland community. And briefly taking it through this process, you can see that we're talking about $700 to $2,300 cost per 2 or 3 visits, 2 to 4 visits. And here's where we start thinking about cost effectiveness. So the summit, pilot summit that we had in Cleveland last fall, the summary from that is the 3 expert panels, actually the 4 expert panels, recognizing the standard of care process need, that the asthma home visit should be closely tied to the clinical care team and the medical care plan, that the visit should have both environmental components and case management, education component, and the cost effectiveness of such programs would most likely be able to be demonstrated when you're talking about the severe patients, those that have failed medical care and had to be hospitalized, and the full ready recognition that the grant programs are not at all sufficient to cover the need. As you saw, our coverage of the asthma patients in our program was 27, but we had 500 a year hospitalized. I mean, we've got to expand this so that it makes sense for the general population. So, talking about cost effectiveness, I went to CDC's publication 2 years ago to pull out the top 3 here. And as you see, the benefit cost ratio varies. The Boston Children's experience shows a positiveness, and the Baltimore unpublished yet experience also. Well, how do these programs then differ from what I've been saying? They are a wider catchment of the asthma population. They're taking the milds and the moderates. Not that we can ignore those. Not that they shouldn't be part of programs, but when we're asking for Medicaid-type payment, I think we're going to do much better in convincing the system if we target to the more severe patients. And so I would see the cost effectiveness of the program being easier to demonstrate with that. So there's an interesting experiment that's being started in Fresno, California. Some of you may have seen recently, where they're selling health impact bonds in order to raise money to do these asthma home visits. So they've taken 200 asthmatic children who have been very heavy users of their Medicaid program, and they sell bonds to pay for the home inspections and interventions. And this program then uses community health workers addressing both environment and case management, monthly phone calls, quarterly home visits, and they project a 30% reduction in emergency room utilization, a 50% decrease in hospitalization, with a net savings of $5,000 per patient per year. And the investors then receive a portion of these savings. If our capitalistic entrepreneurs approaches recognize the cost effectiveness and the value of this program, why can't our public health programs also? So this is what we're currently doing in the Cleveland area. Is a couple of months ago, we brought together all of the HUD, Ohio Healthy Home grantees. We got 6 of the 8, basically 7 of the 8, to attend a one-day conference in Columbus, where we walked through what each of us were doing, and even though there were many complexities, we saw that there was a great deal of uniformity. And we came to a consensus that basically the optimal plan that I previously demonstrated was what the various state programs across the state should be done by the various communities. With flexibility and with the recognition that there should be no age limit. We've been talking predominantly about children, but this should readily extend into the adult age range also. We have not yet had a major conversation with the medical director of the Ohio Medicaid. They're in the middle of a legislative battle relative to expansion of Medicaid to the state of Ohio, as is happening across the country. But we have started a conversation with the Medicaid managed care organizations. Those capitated organizations readily understand the savings. We had our first visit with one of the 5 that we were going to be having to deal with in Ohio. We had our first conversation just last Friday and learned that, yes, it would be a great deal of interest relative to cost effectiveness, since it costs them $7,800 per day for hospitalization. And you start talking even at the high end of $2,300, and you immediately see the cost effectiveness of this. Those of us that like the decreases of morbidity greater than that are happy that at least the economics are coming together finally. And so we hope soon to start a pilot program in Cuyahoga County. So, thank you.